and welcome to the 2024 Conference on Holoprosencephaly. We've got a great program lined up for you this morning, and we're going to get to that in about 25 minutes. But Steve and I are happy you're here. And we just want to start by welcoming everybody and sharing a little bit of information with you about some exciting things that are going to be happening this summer and this fall.
So we apologize for all this stuff from yesterday. I figured we would just kind of joke about that a little bit as far as our technical stuff, because, we're only as good as the technology and our brain power works, apparently. So hopefully we'll get this figured out. But hey, this is our first one. So I think considering, everything and trying to put it together as quickly as we did, with kind of moving the conference around and different things that, this first time of doing a virtual, we've got to work the bugs out a little bit. And the one thing is I can say that hopefully we get this figured out and we do it again. We may be able to do this more frequently. So, we may be able to have some virtual conferences and different things, once a year or twice a year or something in between everything else, just to kind of keep everybody updated and also just to kind of keep our community of folks engaged in what we're doing. So, but we do have some different things coming up. And one of the things that we wanted to talk to you guys about this morning, that you may have seen in emails or things that we posted on Facebook, is our ambassadors for hope. And so what we've done is everybody's an ambassador, really. I mean, you're an advocate for your child. You're sharing information. We share information on here and in social media, but this was a way to look at potentially talking to different families at first and seeing if they were interested in kind of being that first team of people that could be ambassadors and could kind of lay the groundwork for everybody else.
And one of the things I think that is so important about that our ambassadors are doing for us is raising awareness of holoprosencephaly and really out in their communities, educating and letting people know about HPE and telling their story. We started out back in March during Awareness Month with a wonderful group of people who came on and shared their stories. And that just means a lot to our community. It means a lot to us in general, for them to be able to let people know and to educate people about HPE. So that's the great thing. That's one of the great things that our ambassadors are doing. We also have ambassadors involved in a number of the events, the exciting things that are coming up this summer and this fall. Erica Gates, our board vice president, Leslie Harley, who's a wonderful volunteer for Families for Hope, will be involved in some of those together and separately in communities. Ambassador Kal-El Wright and his mom Margie, Brianna Rixenman, so many people, Cameron Self, another board member, Chantel Williams, another board member. So you're going to see in just a minute, if you aren't seeing that already, just a list of really great events that are coming up. We're so thankful to these and all of the people who help us out raising awareness, educating the communities that they're in their states, in their region, and just having a great time doing it. You'll see from some of the events that are coming up. So we're thankful to them. Steve,
and I don't think we're going to change the screen. If anybody is on, there's also an option where you can change your language settings. It's under captioning. We forgot to mention that earlier. So if you need to hear the conference in a different language, we have that capability. You just have to go into the captions and change the settings to whatever language. And there's I don't know, several languages in there. So,
You
so
can
let us
adjust your
know.
settings, turn on captions and select your preferred language. So those are some key things that will help out today.
Yep.
So back to our events, you want to share what some of those are?
Yeah. So, a couple of big ones coming up is August 26th. One of our sponsors that supports Families for Hope quite a bit is Eric Bransky. He's actually the brother-in-law to Brianna Bixenman, and so he has a golf outing that they did last year, and it was very successful golf outing, and they're going to have that again this year, and it's going to be in Fall River, Massachusetts. So we're excited about that. I know Brianna is going to be a big part of that, and I know she's excited about that too. They'll have a lot of cool things that they're going to do. They usually have, I think, some retired athletes from the Boston Red Sox. Not a big Red Sox fan, but hey, if you want to support Families for Hope, I'm all for it. So, and then some of the other things, we talked about with our different ambassadors. Cameron and her husband, Driston Self, they are going to have the Batting for Hope softball tournament. And that benefits Families for Hope and also the Circle of Hope NICU Foundation, which was a big part of when their son Brighton was born. And so they support that. And then the 14th of September, Chantel and Brian Williams will have the Homers for Hope. And this is their second year doing that. And so that's going to be a fun time too. And these are softball tournaments, and they're great opportunities to share about Families for Hope and also support us at the same time. And then on the 14th, also September, in Jasper, Indiana, is where Margie Wright and her son Kal-El will be, and they're going to have a bubble party and festival. So if anybody's near Jasper, Indiana, any of our families out there, and you guys want to come up and share in the bubble party, which I have no idea, maybe they'll make bubbles as big as humans, but that might be kind of fun. And then Leslie's going to be at a vendor booth at a craft fair in Martinsville, Indiana. And then also she's doing something here in Indianapolis with the Community Health, which is who we both work for, and they have a big craft fair in the fall. And so she'll be selling some crafts that she's been making. I think some of you guys have seen the pens and things that she's made, really cool little ink pens. And she's got keychains and necklaces and all kinds of stuff. And so everything has to do with Families for Hope and just it's just a cool thing. So, and then we always have some of our other stuff. We have our costume contest that Families for Hope has done for years, which is always a great way to see the kiddos dressed up in the unique ways that we can take, a child in a wheelchair and create a fire truck or an ambulance or a tractor or a race car or something like that. And so, and then her and Leslie are going to be at an event in November. And then towards the end of November, we always have our Giving Tuesday event. And so with all these different events coming up, there are opportunities for volunteers. And so, even if some of the things like I know with folks being in, let's say Massachusetts, or we've got Chantel's down in Louisiana and Cameron's in Kansas City or in the area, we can always use people to help volunteer for that. Our big push here is going to be the costume contest because we always need folks to help us with trying to coordinate the costume contest. Because believe it or not, it takes quite a bit to get that going. We have the online, deal with everything, but then also it's just monitoring it, promoting it, getting folks involved in it. I think last year we probably had 30 kids that were involved in the costume contest. And the thing about it is it's for all of our kids. So even our kids that are no longer with us, we encourage our families to still participate in that. But We always need volunteers, and we need folks that can just help us with getting the word out, kind of help us managing it, you know, promoting it, getting the donations that come in from it, but just overall, just the whole process of it's just really cool. But so if anybody's interested in that, you can let Susan or I know, and you can always email us. You can email me directly if you want to at steve.harley@familiesforhope.org, or you always have the info at familiesforhope.org, which is our generic email, but it comes to both Susan and I. So either way, just let us know. And then you can always let us know if you have any questions or comments on things or ideas.
If you're interested in becoming an ambassador for Hope and you want to hear more about that, please let us know. We welcome you to join in that effort. And want to talk a little bit about our board members. We've got some great people working with us as board members, and they're just a wonderful group of people. We mentioned, and you met, of course, those of you who don't know Erica, many of you do. Erica Gates is our vice president working under Steve. We have Brian Hargrove as our secretary, Robert Hamilton, Cameron Self, and Chantel Williams. So we're numbering 6 at this time, and
we just actually added a 7th.
We actually did it. So Amy Rose has joined us as a board member, so we'll be welcoming her, and she'll be working with our group. Wonderful group of people, as I said, and they do so much, and we're so grateful to have them.
Yeah, and we're also, we've got a couple other board members that we're going to be talking to that are potential board members, and so we may soon be up to 9. And so, we always have. And I always like to say this, we always have spots open for board members. So if that's something you would be interested in too, you can contact Susan or I, and we can kind of talk you through the process and everything, as far as what it involves, and see if it's something that, is definitely what you would be interested in or what you want to do. Or if it's not, there are other options that we have too, where folks can still be involved, but maybe the sound of being on a board is sounds like it could be a little bit stressful or too much or something. So, but I want you guys to the one thing that we've always talked about, and when I became president, and when with Susan coming on, is this organization was started for all of you, and it was started by you. It was started by 4 moms that saw the need to have a organization that could provide information and support, and just without it sounding redundant, the hope, because there is none there, and there's still not today. And so I really want everybody to feel like this is their organization, because it is. And so, if you're interested in getting more involved, please let us know, because we really want to get as many people involved in the organization as we can, and be able to do the things that people, are hoping to do. Whether it's a conference, or whether it's, different events, or whether it's activities, or whether it's something that's been on your heart for a while or in your mind that you'd like to see Families for Hope do more of. Let us know that too. I mean, that's what we're here for. We serve you guys, and so that's what we want to try to to accomplish for all of you. So
we like to say that Families for Hope is for families, with families, and by families, and that with is so important, because, as Steve said, it's your organization. You are our key and chief partners in everything that we do. So always feel free to reach out and engage with the leadership. You're so wonderful in the community, engaging with each other with so much energy and passion every day, in support of your children, in support of each other. And we want to encourage that engagement with us as well. So ideas, thoughts, questions. There's just not too much information that we can have because, again, we want to provide services and present programs that are meaningful and that really, really help you. So reach out often.
So we still got about 10 minutes before we start our piece that Nancy Clegg has done. So actually I'll take this time, if anybody has anything that you want to ask us while we're on here, you can type it into the chat and we can answer any questions that you guys have or any thoughts that you have on things right now. Maybe we can try to kind of be interactive right now. So don't be shy. If you want to type something in the chat, just type it in there and we'll see if we can answer your questions. Yes, no, maybe.
Well, while you're thinking of, while you're thinking and perhaps maybe putting some questions for us or some comments into the chat, I'm just going to say that you're in for a treat very shortly with our first presentation of this morning. Dr. Nancy Clegg is going to be with us. Many of you know her. She's been involved and at the head of all things research in holoprosencephaly for 25 years. She's the project director for the Carter Centers for Brain Research in Holoprosencephaly and at Scottish Rite for Children's in Dallas, Texas. And she's just a wonderful, wonderful person. Those of you who know her know how delightful she is and just a wealth of information. So we're very fortunate that she's going to be joining us this morning. As you know, the rest of the program today, Janice Scott is going to be with us. So many wonderful people that we are fortunate to have supporting our families with just a wealth of information. And these are people also who value family voice. And I think that they enjoy and get as much out of what you bring and what you have to share about your day-to-day lived experience with your beautiful children. That makes them extra special. They're open to you and your experiences and sharing from their medical backgrounds the information that they have. So very excited about that as we continue to look for. Yes, I see somebody. I agree. We love Nancy. Thanks for that comment. A very shared fact among all of us, I believe. So thank you for that. See anything else there?
Nope, nobody has a question.
Okay.
So I know Nancy's on, and I know our stuff that we have for Nancy is recorded. So Nancy, without putting you on the spot, I just didn't know if you wanted to say a few words just before we get started, or you don't have to, but.
I want to thank you for this wonderful opportunity and that wonderful introduction. And I absolutely consider your organization critical to our initiatives. I always say y'all are our sisters. We could not do it without it. And all of our research, all of the information, all of the support we provide is because of the families. You know, people who are willing to submit scans, blood, tissue, information on the registry, come for evaluations. And the only reason why we know so much information about holoprosencephaly is because parents were willing to do that. Also, all of the pictures in the slide presentation that's getting ready to come up, families agreed that we could take pictures of their children to share this information, with others. And although I'm the speaker for today, everything that I am presenting is 25 years worth of other researchers who have joined the Carter Centers from coast to coast. And I see Dr. Levy on here, of course, Dr. Hahn, Dr. Penner, Dr. Delgado. We've had Max and Ben and Paul and Elaine. And I just cannot thank all of the people who have contributed to our program over the years, in addition to the families. So thank you for sharing your information and thank you for allowing me to speak today. I am in the presentation going to give a very simple overview but the slides are available to you, so you don't have to take notes. All the science detail will be in there. My email address is on the last slide, so if you have specific questions or want to talk about your child, don't hesitate to reach out. But like I said, PowerPoint's available to you, all the materials, more details on a lot of the problems that often accompany HPE. I'm not going to talk about seizures and diabetes insipidus and things in great detail. That's all available on our website, but we will have Q&A afterwards, and I'm welcome to take any questions. And thank you again for allowing me this opportunity.
Great. Thank you, Nancy.
Thank
We
you.
appreciate the partnership that we've had with you guys and continuing that into the future. So you can't leave us. We can't leave you.
Well, we are getting very close to sharing the presentation of Dr. Clegg, and just checking to see if any of you have any more comments in the chat.
Do we have any, I know one thing, do we have any new families that are on, maybe that, you know, are new to Families for Hope and new to, you know, holoprosencephaly with your child, or anything like that? Do we have anybody on like that, or do we have anybody on here that maybe has never been able to make it to a conference, but because we're doing the virtual, it's opened up that opportunity for you to be able to join us and to share in you know, the information and you know, and the camaraderie of what is, you know, Families for Hope. Do we have any folks like that on here this morning? Well, Eric, okay, cool. Well, I'm glad. It's something that we've talked about, wanting to do it with a virtual conference. A lot of reasons, because, you know, we do have that in-person conference, but a lot of folks, you know, when we look at how many people we have in our database, you know, we've got probably 1,500 families that are in there that we, you know, constantly are trying to send information out to and interact with. And so when we do the in-person conferences, believe it or not, less than 3% of that number is usually what comes to the conference. And so, you know, I like it because, you know, with our kids, you just never know what's going to come up if there's a surgery. And the other thing too is the travel costs and being able to get to a conference and work letting you off and stuff. So we get that. And so, you know, I'm glad to hear that, because that's what we, you know, kind of what I, you know, thought of whenever we talked about doing a virtual conference. And so I think that the feedback you guys are giving us.
And this is Amy's first time, I see.
Yep.
And Jody, who says you've attended in person in the past, but you would not have been able to this year. So
Yep.
Glad that
Yeah.
you're with us today.
Yeah.
First timers and folks who would not have been with us this year. So
bearing with us in all of our, you know,
thank you
our-
for your
our
patience. with
technical
us.
stuff and different things. So we'll get things figured out. But I think yeah, that's the cool part is knowing that, you know, we're opening it up for folks that wouldn't been able to make it, and you guys can be a part of it. And so that's really cool. So I appreciate that.
Andrea, also a past attendee who would not have been able to make it this year. So glad you're here. All of you who fall into that category.
Yeah.
Becca,
So
good to see you.
So we're gonna pull up. I believe we're gonna pull up Nancy's slide presentation and go ahead and run into that. I know a couple people.
Good morning. This is Dr. Nancy Clegg. I am the National Holoprosencephaly Project Director. I appreciate your time this morning, and I want to visit with you just briefly about some general information about holoprosencephaly and the Carter Centers. So first, what is holoprosencephaly? Well, it's a birth defect that occurs within the first few weeks of pregnancy. And what happens is that the fetal brain does not grow and divide into two separate hemispheres as it is supposed to during early pregnancy. We call this incomplete separation of the left and right hemispheres. So you see the picture on your left is a normal brain, and there is clear separation of the left and right hemisphere. Whereas in holoprosencephaly on the right side, you see there are areas that did not divide, where the arrows are pointing. So how is HPE classified? So we have looked at hundreds of neuroimaging studies and classified, and there are 4 main types. There is alobar, semilobar, lobar, and middle interhemispheric variant, or MIH for short. So in alobar, the brain is not divided at all, and there are usually other severe abnormalities within the brain. So you'll see a large area, we call those dorsal cysts, it's just fluid, there's fused thalami, there are absent, parts of the brain. In semilobar, usually there's some division in the back, but it's not divided in the front. And there may be some other moderate abnormalities within the brain. In lobar, the brain is fairly divided, but there's some mild abnormalities and some mild areas that did not separate or develop well. And in MIH, it's divided in the front and the back, but there's some non-separation that's in the middle. So how common is holoprosencephaly? Well, it is actually one of the most common fetal brain malformations. In fact, it's estimated that it's as high as 1 in 250. But it only affects, if you look at the statistics, between 1 and 10,000 live births. And that's because most fetuses with HPE do not survive to delivery, and a lot of children with HPE do not make it past the first 6 months of life. However, HPE is a developmental order, and this is very important. It is not fatal. It is not progressive. Most of the poor survival is due to other anatomical and neurological problems that go along with the disorder. So what causes it? We don't always know, but common risk factors that we see is maternal diabetes, infections that occur during pregnancy, various drugs that have been taken during pregnancy, and even low maternal cholesterol levels. There are also chromosomal abnormalities and gene mutations. And chromosomal abnormalities include duplications, deletions, ring arrangements, and it is estimated that almost 25 to could be as high as 50% of HPE is due to abnormal chromosomes. However, we also have many children that have normal chromosomes, but they may have gene mutations. And these mutations can be inherited or new or isolated just in the child with HPE. So what are some of the clinical manifestations of HPE? There can be craniofacial malformations, microcephaly, which is a small head, hydrocephalus, which is fluid in the brain, endocrine deficits, epilepsy or motor dysfunction, GI issues, pulmonary issues, motor dysfunction, developmental delays, and even behavioral problems. So some of the facial abnormalities that we see is hypotelorism, which the eyes are too close together, and hypertelorism, where the eyes are too far apart. In rare circumstances, we also see cyclopia when there's only one central eye. A lot of our children have cleft lip or palate or both. They have a very broad, flat, single nostril nose. They have one central tooth, or they have a proboscis, which is a long, thin nose located on the forehead. So these facial abnormalities, there's a wide spectrum of findings. So here's pictures from our clinic of very, very mild findings to the very severe. This is a picture of the single central incisor that I was sharing with you. Sometimes it could be very subtle or sometimes very pronounced. This is a single nasal opening. This is hypertelorism, or the eyes that are far apart that have this flat nasal bridge. This is a child that has a cleft lip, hypotelorism, or the eyes are too close together, a missing nasal bridge, and low set ears. This is a child with cleft lip, and this is what she looked like before and after her repair. There's also digit and limb abnormalities that we see sometimes, and even spina bifida. Microcephaly is very common in holoprosencephaly. In fact, almost 3/4 of our patients have microcephaly, or a very small head. And usually when microcephaly is not present, it's because there's hydrocephalus, or extra fluid in the brain, which is the underlying problem, and then they have large heads. 1/6 of patients required shunting due to this hydrocephalus, and children with a lobar are more likely to have hydrocephalus and shunts. This is a picture of a pre-shunt, what the brain looked like, and this is post-shunt. After all that fluid was drained out, the brain filled out the skull, and then we could clearly visualize the structures, and this child went from an A-lobar to a semi-lobar diagnosis. There are also common endocrine issues. So they can have diabetes insipidus. This is not diabetes mellitus or sugar diabetes. This is a salt diabetes. They can have thyroid deficiency, cortisol deficiency, or growth hormone deficiency. And almost 3/4 of our patients have some kind of endocrine problem, and especially diabetes insipidus. And of course, the posterior pituitary dysfunction is much more common than anterior. Epilepsy is also a common occurrence. In fact, 40% of patients have epilepsy, and it is not associated with a particular type of HPE. If you look at the stats we have here from our database, A-lobar, semi-lobar, lobar, and MIH all have, fairly similar epilepsy patterns. So the majority of our patients, 67%, had at some point in their life almost daily seizures. And then currently, they improve over time, and eventually almost 40% are seizure-free. It's very important to confirm the epilepsy. There are a lot of types of jerking events that look like epilepsy, and we see all of these different events in HPE. So they have myoclonic jerks, they may have sleep myoclonus, they have very exaggerated startle reflex, they could have chorioathetosis or true seizures. The treatment options can include drugs, a VNS, ketogenic diet, or surgery. There's also oromotor dysfunction, and these are feeding and swallowing difficulties, and these can be present with or without a cleft lip or palate. There's a lot of choking, gagging, slow eating, and vomiting. And in general, the more severe the HPE, the more severe the feeding difficulties. But in general, for all types of HPE, 75% of HPE patients that we have seen in our clinics have G-tubes. There's also other gastrointestinal problems, and these are both due to the anatomy and also some neurological causes. So a lot of our kids have reflux. They have delayed emptying, impaired motility, constipation, failure to thrive. There's also pulmonary issues. This is also because of this abnormal anatomy. When you have a cleft lip and a cleft palate or septal deviation, you get excessive secretion. They kind of pool, in the back of your throat. So, and they have excessive secretions as well as GERD. They have poor suck and swallow, impaired cough, this pooling of these secretions. They can have aspiration and even end up with pneumonia. So for feeding difficulties, these are our Carter Center patients over 1 year old, 2/3 have ended up with a G-tube. There's also motor dysfunction. And again, the more severe the HPE, the more severe the dysfunction. So a lot of our kids use mobility devices, everything from walkers to wheelchairs. Some of the common motor and movement impairments that we see are spasticity, weakness, dystonia, contractures, and chorioathetosis. So there's all kinds of treatments for these motor impairments. And in our clinic, we use a lot of medications, baclofen, Artane, Botox. There's also surgeries, different kinds of therapy, bracings, and various mobility devices. The treatment goals are to increase the range of motion, increase the mobility, improve hand control, head control, better positioning. Sometimes it's just to ease hygiene. The legs are so tight, we can't change the diapers. To increase that decrease the energy expenditure, decrease self-injurious behavior, and to decrease pain. Developmental dysfunction is very common, and severe to profound developmental delay and cognitive impairment are common in the more severe forms of HPE. And the more severe is typically the more severe dysfunction. In mild, for an example, in our database, half of our low-bar patients are able to walk independently, use their hands and arms normally or with just mild dysfunction, speak single words or even multi-word sentences. Whereas in our severe HPE, like a low bar, none of our patients are able to walk, reach, obtain objects, or speak. That doesn't mean they can't communicate or that we can't understand and can't assist them, but they are severely developmental delayed. We also see a lot of behavior disorders, and these typically are across all types of HPE. There can be aggression, agitation, self-stimulation, even self-abusive. A lot of our kids bite their fingers or bite their hands, even to the point of, causing injury. So all of these things that we saw in clinic, and finally we saw a patient in 1996, cute little kid named Chance, and the family was very frustrated because they couldn't find any information about it. All of the doctors were giving them, gloom and doom and telling them horrible things. And, they wanted to know more about this and wanted to not only help their son, but help patients across the globe. So they sponsored a neurobiology research conference and invited the world's leaders with brain malformation all to come to Dallas, Texas, and discuss this disorder and figure out the best strategy to find out more information and to help families. So initially, we established 3 clinical research centers across the United States, at Stanford, at Scottish Rite at Dallas, and at Kennedy Krieger at Baltimore. We decided to focus on 2 major things, which was education and support and research. And under education and support was not only just for families, but healthcare providers and the community. And for research, the best way to gather all the information about patients across the world would be to create an international registry, to do specialty clinical research evaluations, to really reach out and involve networking with genetics and neuroimaging and cognitive, and to create a database to put all this information in from kids across the globe. In 2000, we did the first family conference on HPE. And, we really wanted to hear what the families had to say. And, families talked to us. We did patient evaluations. We figured out how patients could best support, each other and how to get the information we needed to really, bring and advance knowledge of this disorder. And, it was decided we needed to do family-to-family support and more family conferences and create a Facebook page. And of course, Families for Hope, which has been, our sister for a long time now, trying to help bring the scientists and the families together and figure out exactly what we need and how to serve this population. This family also created a family resource center in 1998, in which anybody across the globe could contact this resource center to get information, to get support. You do not have to be in Dallas, Texas to use this center. Everything is now online. You can make phone calls. We have patients, like I said, across the world who now use this resource center to help find out information about this disorder. We also created a lot of brochures and pamphlets and handouts. Of course, now we have everything online, but did a lot of mailings and, passed out a lot of information, because not only did the families not know, but, their therapists did not know or their doctors did not know. So we were really trying to expand knowledge of HPE. We also created the first video about HPE. It's called Living with Hope, Understanding Holoprosencephaly. And we even won an award for it, got a Freddie Award. We also started disseminating information to the community. We went to all the national conferences, passed out all these paper forms and, visited with doctors and, try to really help everybody understand what this disorder is, to refer all those scans, get genetics for these kids, really get a comprehensive handle on what was going on. We established our first HPE clinic in 1998 and started off very slow and then ended up having quite the waiting list of patients to see and evaluate and learn more about the disorder. Currently, everything we have is online, hperesearch.org, and there is general information. There's information about the Carter Centers. Our movie is now on the website. All of the research articles that we have published, our international registry, everything is on this website. So please go and visit and look at all of the information that is there. We also, big part of this was the registry, so we could find out more information about this disorder across the world. So again, if you'll go to our website, you will see an option to register online. It's in English and Spanish. You can also download all of the forms, and Daniel Gonzalez is our contact person for the registry, and the information is on the website. We also have this huge database that we established in 1999. And we put all of the information from any child from across the world into this so that we know more information about HPE. First of all, we were doing a lot of clinical studies, gathering information from clinic visits at Kennedy Krieger and at Stanford and at Scottish Rite, as well as information that other doctors would send us so that we could really learn the differences in the types of HPE and the common problems and the best treatments that we could find. And we put all of these detailed evaluations and treatments and images, into the database to see what things were effective and which things were not effective. We also really increased our enrollment of children with motor disorders because that seemed to be the thing from parents that they most were frustrated with and wanted more help for their children. And we did various studies on different devices and different medicines and, robot therapy and, brain scans and everything, trying to learn more about these specific motor disorders. We also started out working with the National Institutes of Health with Max and, learning about the identification of gene mutations. And of course, now, that has expanded and we're working with, Paul and Seth and, other researchers, doing genetics across the world. We also have continued to, want to learn more about, neuroimaging. And as of yesterday, our number was 693 MRI and CT scans that have been confirmed with HPE and reviewed and entered into our database. We have published over 100 articles. Again, we have gathered all this information. It is extremely important that we publish it so that leaders and doctors and therapists across the world can read about what are the best treatments or what are these different categories or what needs to be done if we are truly going to help patients across the globe. And then recently here, the NIH did a project on adults. And of course, as our population has aged and grown up, we're interested more on, the long-term effects of treatment and, how our kids do now that they're adults. It used to be people would call me and say, oh, I have a 15-year-old. They're the oldest living child with HPE. And of course, I knew there was a 40-year-old that was coming to clinic. So, trying to share and give hope to families and let them know that, we do have lots of adult patients out there who are doing very well. So the Carter Centers have been funded by the Don and Linda Carter Foundation, the Crowley Carter Foundation, and the Carter Chancellor Urschel Neurobiology Research Fund, and we appreciate all of their supports for many, many years. Thank you very much. All of the information in greater detail about all of these things is on our website. I didn't want to give in-depth lecture. I could talk about any topic for over an hour. Please don't hesitate, though, to reach out to me, call me, email me. Let me know what your questions are and how I can help. Thank you very much for your time. Either I went way too fast or I was so great that everybody's questions were answered.
So we've got one coming through here.
We have a question that is from Amy. It looks like Amy wants to know, how would we join an adult HPE study?
So that study is now complete and published. However, we are still collecting information. So the best way is to go to the registry at the Carter Centers and enter all the information about the adult. And so when we do the next article, we know exactly who to reach out and, that they're doing well and all of the information. Even if you have registered in the past, the best way for us to make sure we have updated contact information as well as your permissions, because sometimes early on you don't want to share a lot of information, but now you would really like to be part of a publication. You can enter your preferences. You can also ask questions that way and provide information, and then we will get back to you. So hopefully when the next article comes out, we will have a list. Great question. Thank you.
And Eric would like to know, is there any specific type of therapy that helps, such as DMI or intensive therapy sessions, multiple therapies over 3 weeks?
I believe we have other sessions during this conference that they're actually going to talk more about therapies and those kinds of things. But absolutely, therapy works. Whatever is available to you and whatever you can afford and whatever is local or your insurance, take advantage of it. I know that it varies across state as far as what is available, but therapy helps absolutely. I can't answer specifically. It's a great question, Eric, by the way, because HPE is so different per patient, right? So some just have spasticities, others have dystonia, others have chorioathetosis. It really depends on, what motor issues are there as far as what specifically will work for your child. But absolutely across the board, being involved in keeping those muscles loose and exercised and, help with developmental gains. But I don't have anything specifically that if you have HPE, do this, and it's the best kind of therapy. It really kind of just depends on your individual child and what's available to you.
Thank you.
I had a question about the transition from pediatrics to adulthood or adult medicine, as far as like the care, because I know we have some families that have said that their kids still see their pediatrician even as an older adult. But can you kind of give us some ideas on that as far as what you've seen or how to make that transition?
Unfortunately, that definitely varies across states and across countries. So, some schools allow you to not graduate. So you continue, in the schools. Some of our hospitals here in Dallas, 21 is the cutoff. Certainly you can continue to then, and then you cannot. In general, I think leaving the world of pediatrics and going to adult care is a nightmare for most families, because they had that wonderful integrated care and everybody understood your child and all your services were in one place. One of my families that recently transitioned, 2 years ago transitioned, said that everything she ever needed was, at the Carter Centers, at the Scottish Rite. And now she had to go to 14 different doctors because there was a separate GI doctor and a separate endocrine doctor and a separate seizure doctor and a separate, G-tube doctor and a separate whatever. And, trying to figure out who's going to reorder the medications or who needs to do this and that, really varies. So there is no magic answer here. It's just, unfortunately, state by state, and then what your pediatrician and your insurance or your funding will allow. But it is a big source of frustration for us because we just do not feel that our kids that leave us get the same quality of care.
Have you heard from Max lately? I've always been trying to get a hold of Max, and I don't think I have his number anymore, so I just didn't know what he's doing these days.
He recently came and did a big outside guest at UT Southwestern, and was here lecturing, and texted me, come on over. And so I got to go over there, and then we had lunch, and I got to listen to the lecture, and we chatted and all that. He looks fantastic. He misses our kids. He says that, missing the conferences was, hardest for him.
Yeah.
And, it's still his passion, and he still uses some of the kids in some of his slides and talks about it and all of that. But anyway, doing great. I've also run into various other people who have worked with the Carter Centers over the years, and they all say the same thing. They really miss it, but, had other things going on in different directions in their life, but they're doing great.
I think I'll have to get with you and get Max's contact info. I'd like to pull Max back in. So I actually like to pull everybody back in, but have to do it one at a time. But Max is one of those that I had talked to a couple years ago, and I think he was interested in trying to keep in touch with us as far as what we're doing and things. And I had kind of told him the directions and stuff that Families for Hope was headed. So maybe now is a good time to reach back out and get a hold of him. So looks like.
What forms of treatment are offered at Scottish Rite?
Yeah, that's from Eric L.
Yes.
Is Eric lives nearby to Dallas, where I go into a long spiel?
Yeah, Eric,
So,
are you close to Dallas? He's
Yes,
in Austin.
He's in Austin.
So in order to be seen at the Carter Center in Dallas, first of all, you have to submit a scan, and we have to confirm the diagnosis. And then we set you up to come to our clinic for the full assessment, evaluation, and just to find out what kind of services you need. So you say what kind of treatments are offered. Depends on what kind of treatments your child needs, right? So HPE is treated by symptoms. We treat seizures, we treat motor disorders, all of those things. We do not have an endocrinologist. We refer all of those out. That's not a service that we offer here. And so it just kind of depends on what things your child needs as far as what we are able to offer. We do recommend that that Dallas is not their local area, that they keep their local doctors, but use us for recommendations, additional information, and bring that back. And then our doctors, can confer with those doctors. Just to let you know, right now we have a 6-month waiting list. So, don't think, oh, well, I'm going to be there in 2 weeks. We'll stop on by. So, it is quite a laborious process, to do all of those. But it's going to be the same at any center across the United States. It depends on the problems your child has to what kinds of treatments that you need, for that. We also have a variety of camps for special needs. We have a constraint-induced movement therapy program. We have an infant CP. I see Andrea's on the call as well. She's part of a big initiative that we're doing right now through a PCORI grant on trying to make sure we're asking the right research questions and offering the right things and directing research based on that. Her child has motor disorders, and that's a big topic, that we are working on. And a lot of our parents, have suggested. Part of this initiative, I see there's another question in there about adults, is we are including adults as well as children to get everybody's perspective. And what was important maybe when your now adult was a child may change now that they're an adult, right? So we're getting everybody's perspective, on exactly what we need to go and where we go next kinds of things. And also what is not available in the community and what we need to reach out. So we have a whole list of resources now for all of our local families for different activities, participation, activities that, they can participate in.
Do you know who our oldest child with HPE is? Adult?
So we have a couple in their 40s. We also have some very mild parents that did not know themselves that they had HPE until later on. So we have parents that are even older. They're what we call microformed, or, they're minorly affected. They just thought, they were having some issues as they went along, and now they've actually been confirmed that they have HPE. So we have,
Wow. Okay. So I don't know. I haven't seen any other questions pop up.
I see a question from Amy about dealing with a new PCP. So frustrating. I definitely hear that constantly. And, I probably speak for all parents in saying that you have to train your PCP. You have to be the advocate for your child. You have to bring them information. You have to demand, I have parents that have a little notebook when they're hospitalized. This is what diabetes insipidus is. Do not do this. Yes. This is what, whatever. So I can't teach. We try, with awareness and our medical students, our fellows, and our residents. But unfortunately, a lot of it is just, teaching your PCP. But they could also reach out, to our physicians and to other people who have that. And she can also, if they won't do that, here's the Carter Center website. Here are the articles, perhaps you could educate yourself more on a child like mine, or, these are the current treatments. But I wish I could fix all of them, but I cannot. Let me see if I missed any other questions.
Other questions?
So let me see if anybody's, do you have a handout about diabetes insipidus for education?
So there is some general information on our website, as well as an article. But I think I also at some point kind of created one. So let me go see if I can pull it out. So Tina, if you want to email me at hpe@tsrh.org and remind me, I could even create something for you.
Cool. Let's see. Oops. No, they're popping on here quickly. Let me see if I can. One thing that is very helpful for us, maybe for other families, is if their city has a comprehensive care program where the PCP is experiencing handling kiddos with multiple issues. Our PCP visits are 1 to 2 hours and not 15 to 20 minutes. It's a norm. It's a real struggle for when there's a lack of time. And that's what I was going to ask, I was actually going to ask you when you said that, because we know that you kind of partner with the families as far as with the care and stuff. How do you get a good response from our families, from their PCPs or specialists or something when they've kind of added you into the mix? I mean, are they willing to share, information with you and things of that nature so that you're part of their care plan? Or do you find that has some difficulties to it based on whoever the doctor is that you're dealing with?
I think we have some excellent ones that really wanted to learn to take better care of their patients. I also get a lot of calls from residents who or interns or somebody in the ER. I've never had this before. Help, what I need to look for, what I need to do. Probably some of them that really should reach out do not. That's why I'm saying if they could go and read the articles or look on the website, but they're not going to just call. We do not require that we have to have the patient's name or any PHI. They can just ask general questions. So it's not a matter of, they have, they're not supposed to share PHI, private health information. So, we do a lot of that. So, Tina, it's hperesearch.org is our website.
HPE research.
Does anybody have any, keep the questions coming. We've still got some time, and if Nancy's willing, we've got a little bit of, I know I was going to mention, because Nancy made this comment about families that take, if their child has like diabetes insipidus or something, they may have information that they take with them, if their child has a hospital stay or something. And I remember when Sammy was alive, we had a book, and that book had all of his information in there and his diagnosis and all the different things, had his medications and why and how and everything else. So I don't know if any, families have done that, but I would suggest, doing that. I mean, we had home nurses, so that probably made it more important for us to have it, because we also use that to educate our nurses coming in. But I can't tell you how many times going to a new doctor, or if Sammy had to go into the hospital, even though the hospital he went to knew him, you still had new doctors, nurses, residents, everything else. But we used it as a educational piece too, because it opened them up to the world of HPE. But, it just made life a little bit easier when we had the explanations in there about, why and what, was going on with Sammy and everything else. So that seemed to kind of help us a little bit. So I just thought I'd pass that along and to other families, because that might help them as well. So just a suggestion there on that.
So I love my clinic, because all my moms with a child with HPE have color coded numbered binders.
There you go.
In fact, somebody even asked me, "Was like, did you pass these out?" They all have it. I'm like, when it's that complicated and you're trying to coordinate all that, and plus, when you try to fix one thing, you cause problems with something else, right?
Right.
Or this medicine or whatever. So it's very, very helpful. Of course, now there's all kinds of wonderful apps for your phone where you can keep information on there as well. So trust me, most physicians, I know we absolutely love it. If you bring information and you have your results and all that, it's always welcome and always willing to learn. I don't think anybody gets mad that you're trying to do all of these things and trying to remind them. The residents or interns or whoever else you see may be more willing to ask questions, but then they take it back to the other people. So, one way or the other, the information gets shared. So absolutely, I do recommend this. There are a lot of cerebral palsy sites that offer these books where you can put all this on there, as well as apps. And of course, CP is caused by holoprosencephaly. A lot of our kids have CP. So certainly reach out and look at some of those resources. And, you can do everything on your phone these days. So, you can do that. But absolutely, I think the biggest job as a parent is trying to teach the world about your child.
Yeah. So Tina Carter is it common for urinary and or kidney issues with HPE?
So the answer is yes, because if you are not upright to urinate, the bladder may not fully empty, and it sits in there, and you can get infections and inflammation, and you may not be able to empty totally, and then it can back up, and then you can have kidney issues as well. Unfortunately, a lot of medications that are used to treat a variety of symptoms that accompany HPE can cause urinary and kidney issues as well. But, like I said, there's just not complete emptying is the main thing. So if you're on your back most of the time, or in a diaper, which also leads you to more infections, at the site that can travel up the urethra. So, even with the best of hygiene, everything is right there together, especially with girls. And, that always puts you at risk. But absolutely, there are definitely some issues there.
I would assume, I was going to get to Kristen's question, but I would assume too, sometimes medications might impact the kidneys and urinary tract too.
Correct. And it also depends on, how dilute your urine is. Of course, that's the good thing about diabetes insipidus. you're constantly peeing this very dilute urine, you're keeping it flushed out, you have less problems. But those people who get dehydrated, it just doesn't get flushed out well.
Mhm. Nancy, we have a question about maternal cholesterol. Should the medical community be promoting cholesterol testing to those who are contemplating getting pregnant? Is that something you think?
Well, absolutely, they should. I think that should be part of any new workup. Unfortunately, because HPE occurs within the first 2 weeks of pregnancy, so you don't even know you have, your child has HPE. It's too late if you wait, until later. But absolutely that, and make sure you're taking folic acid and all those good things. So, if you're thinking about getting pregnant, you should be doing all these things proactively long before you try getting pregnant. Would be wonderful if that's how pregnancy worked. However,
Yeah.
most of the time you're pregnant and it's way too long and your, HPE is already there. But, if you're thinking, all of those things, absolutely. And the reason why it's not high cholesterol, it's low cholesterol. Okay.
Yeah.
Because that is a catalyst, right, for all the things that make good brains and all of those things. So, we see a lot of people that were severely dieting or ketoacidosis or, other problems before they knew they were pregnant. Okay.
Yeah.
But of course, once they knew they were pregnant, it was too late. So it's both ends and not just high cholesterol. But, if you have high cholesterol and you're on all these medicines, maybe it goes too low. So, even though your original diagnosis was high cholesterol, it may then be way too low, to do that. But certainly any health condition that you have or problem that you should, be well in control. And the same thing with maternal diabetes is a high risk. If you're in good control, not having ketoacidosis, not a lot of other problems, your pregnancy will be just fine and you can have very healthy children. But you are, totally out of whack and, up and down and all of that, it certainly, sets a risk factor. So, anytime you have any health condition, to absolutely, before you get pregnant, work on the best plan. Let your physician know I'm thinking about getting pregnant and, be monitored closely.
So I wonder if would these be appropriate to have like public service announcements about them or just with, with Families for Hope? Something that we can share that, that information, in coordination with you guys, that these are things that maybe families should, because I think about with weight loss medications now, and you've got the Ozempics of the world and all and different things that they're finding out that there's some relations to different, birth defects and different that they're looking at. So I just always wonder if that's something that, we should at least keep our families aware of. Because like you said, if your body's out of whack, does that open you up for different things? And the answer I've heard is yes, because it's not just HPE, it can be, Down syndrome and other things, because if you're older and other things are out of whack, it can kind of cause some of those things. So I don't know if that's something.
My recommendation, and it's part of all of the things that a regular gynecologist would do, is at your annual visit to say, we're thinking about having a child, I'd like a full workup, or I'd like this tested, or what do I need to do? And it should be an annual conversation with your, gynecologist, until you, have the obstetrician. But this should be way before, is whatever chronic health condition you have, I'm struggling with this, or I'm working on that, but just, in general, and, to keep up with all these. Everybody's really great after they're pregnant. Oh, I'm going to start taking these vitamins and I'm going to go see my doctor and start doing all these things. And now I'm going to exercise, but no one's doing it proactively. So to have that conversation at your annual woman's exam, will prevent a lot of problems. You can start taking prenatal vitamins, before you even think about, getting pregnant. Healthy thing. There's no harm in it. So, there again, to go ahead and start that.
I see Kristen right here. And then Kristen had so Jessica says, Kristen was diagnosed with T1D due to her pancreatic damage from the repeated pancreatitis. Sorry. Has this been something that has come up with younger kids?
So there are certain seizure medicines that can cause problems with the pancreas. So we have seen that. Is there association with HPE and the pancreas? No. But there again, pancreas can cause also as a part of diabetes mellitus, sugar diabetes. And we do have a few kids that have that. You know, it also is part of, like I said, seizure medicines and other things. So yes, we have a few younger kids that may have it. It's not necessarily the HPE that caused it, but other problems that the child may have.
And then Eric had a question. He said great suggestions, you know, that we talked about earlier with having information on your child, especially if you have to go to the ER and things like that. He had a question though, is there any study on how frequent there could be another child born with HPE?
How frequent?
I think they're probably thinking, okay, if they had a child, you know, born with HPE, what's the probability that they might have another child with HPE?
Great question, complicated answer. Okay.
Yeah.
If your health condition contributed to that, you know, then that same risk is there. If you have a chromosomal abnormality or a gene mutation that is inherited, that same risk is there for each child. If you have an unknown cause of your HPE, there's no chronic health things, you've looked at all chromosomes, genes, and all that, you know, it is unlikely that you would have another child. However, one little thing to note is we are still discovering more and more genes that are associated with HPE. So absolutely at one time we would say, oh, we tested for these 4 things. You do not have an inherited thing. Mom got pregnant and had another child with HPE, and then we discovered another gene. And that's how we keep discovering, you know, more of these, because obviously, you know, we have several parents who have more than one child with HPE, right? And I remember several conferences when parents told me, but it's not genetic. And Max's answer was, well, it is genetic. We just haven't discovered it yet. So, but if you have had a complete genetic workup, there is no chronic health conditions, you don't live in Chernobyl, your, you know,
Yeah.
your lifestyle, your exposures, it would be very unlikely, you know, to do that. To be on the safe side, most obstetricians say that once you have a child that has HPE or any special needs, you have a 14% chance of having another child with special needs. And I think that's just kind of a catch-on thing that, you know, something was there and obviously something we don't know. So they still give you a very small chance of recurrence.
So it sounds like the common theme for folks is to try to do as much, I don't want to call it pre-planning, but you know, I mean, do as much as you can as far as on your end of things, you know, with talking to your OB about different things, you know, and making sure that you're, you know, kind of open and honest with your doctors on your health plans and getting yourself checked out and you know, maintaining, you know, whatever healthy lifestyle and things like that. I mean, just making sure that you're more proactive than reactive, I guess, is what I hear.
Well, with modern technology, we even had one family that they did have a gene mutation. And so they tested all the embryos to find out which one didn't have it and only implanted the one that was gene mutation free. So there's other ways, very expensive ways, you know, that, you know, you can, even if you have something that's identified that you cannot change. But
Right.
Long, complicated answer to say we can't always predict, but all those contributing factors to having a child with HPE, if they're still there for the second child, they were there for the first child, you know, there is that possibility you could have another child.
Eric, oh, sorry.
Okay.
Eric, did that answer your question? I think we probably did, because but
Nancy, do you think do you have knowledge of more babies being born today with HPE, or are we just more aware due to social media?
That's a good question. Of course, I see a whole lot more, but that's because people reach out, right? But I also know that I'm having less and less that register and do all of that. So I think the option early on for early diagnosis, and a lot of families are terminating the pregnancy, certainly very common in other countries. So maybe there's just not as many living children. It's not that it's worse, but good prenatal care and having that information, parents are making choices, for that. But we certainly have more environmental factors probably that are available. Hopefully we're getting a better grip on genetics, and as far as that, and health conditions and maintaining a healthy lifestyle. So I would like to see it go in the opposite direction. But anyway, hard to answer that question as well. Y'all are asking really good questions.
we've had practice now.
Any thoughts on Elon Musk brain chip?
No comment.
I don't blame you. Hey, as a follow-up question, what we were just talking about as far as seeing more children with HPE, do you guys just see or hear about ones in the US, or are you starting to see any kids worldwide, as far as maybe people reaching out to you, or that have found you all and share their information? I mean, is that something that's happening at all, or?
Well, absolutely. And thanks to the internet, we definitely have more international contacts than we ever did before. So, and physicians from other countries that, want to send scans and, have things confirmed because they may not have seen it.
Okay. Because I know we've seen an uptick in families that have found us. And a couple of them have mentioned you guys, as far as I think they found you first, and then and everything. And then obviously we always send folks to you when we get new. But I was just curious, because we've started seeing more families internationally now that are being diagnosed. Their child's being diagnosed with HPE, and so I'm glad they're finding us, because I never know how the care differs from here versus over in other countries. I know how it differs here in the US, just state by state, but I know other areas have more universal health care and things like that. But I thought, we're seeing an uptick on it, and so I just wondered if you guys were as well. So it sounds like
Absolutely.
you are.
Love social media and the internet. Like I said, my beginning years was, mailing paper packets and VHR tapes and, all of that. So it's real, and getting paper newsletters, in the mail and all of that. So absolutely, there's definitely more and more people reaching out from other countries.
Okay. That's good.
Great. Well, do we have any other?
I don't think I've had it. Does anybody? We've got maybe about 5 minutes left. So if you've got any other questions, keep sending them through. Let us know. I think Nancy's, she shared, what is it, HPE at tsrh.org is the email. You say .org or dot? Okay.
Yes.
So I want to, just throw that out there. So if anybody didn't hear that before, and then you've got the hperesearch.org. So anybody that wants to, if you've got other questions that maybe you didn't feel like you wanted to ask today, or if you just need more information, I would encourage you to look at their website and reach out. Like I said, we've had this partnership now ever since Families for Hope's been So we're 18, almost 19 years old. So we're entering adulthood now. So that's kind of how I've looked at it. I've told people, I said, we went from infancy to, being a child to preteen, teenager, and now we're entering into adulthood as an organization. So, we've grown a lot over the years, but I think, our families continue to look to us to provide them with information. So I really appreciate everything that you guys do. And I, like I say, I appreciate the relationship we have with you too. So.
Ditto, and thank you for the opportunity to speak today and share a little bit about the Carter Centers and HPE. And certainly we would not be where we were without y'all. And,
Yep.
Appreciate that. And it's fantastic to be able to refer families and for them to get the support and hope, because, I'm on the doom and gloom side of things, trying to change things, but I realize I'm the big bad, caretaker, health care provider over here. So, and sometimes parents want to share with you, but don't want to, share with us.
Right.
But also just for everybody to know that you absolutely, like for the registry, filling all of that out, you absolutely have a choice. I don't want to be involved with research. I don't want to share any information. It's your choice how much or how little you want to participate, in any of our programs. So just let us know how we can help.
Yep. And Eric, in answer to your question, the website is hperesearch.org. Now the email is hpe@tsrh.org. Hopefully that helps you. Yeah.
Yes, that's right. Thank you, Nancy.
All right.
Well, thanks so much for being with us. We really appreciate your taking time with your presentation and to answer us our questions in the Q&A. Thank you so much for your time this morning.
Thank you very much.
All right. We'll talk to you soon.
Mm-hmm. So we're just ahead of our next presentation, which is Nancy Scott. Janice Scott, I'm sorry. Janice Scott, who'll be joining us here at 11:30. She's going to be talking about how to quantify adequate growth when your child doesn't fit the standard growth charts. Janice is a clinical manager. She was a clinical manager at Scottish Rite for Children's. She is now transitioned into her own private practice. And so we're really happy to have her with us. She's had years and years of clinical experience there at Scottish Rite, and of course in her own private practice now. So we want to welcome her. Janice, I think she is there. Good morning. Hello.
Good morning. Good morning. How are you? I was turning my telephone off so nobody calls while we're here. And thank you. And I will tell you, this is my last week at Scottish Rite. A little bittersweet. It's been a joy to come back and work with the team, especially Nancy and all of our families. I miss not having our own HPE clinic, but I do. I find the kids where they are. Whatever clinic, ortho, neuro, developmental peds, I will find you if you're here at Scottish Rite. So good. I can go ahead and start if you're ready for me to.
Yep.
Yes, we're ready.
Right. Okay, good enough. There. So like Susan said, I want to talk today about and kind of echo a little bit of what the conversation was and what Nancy was talking about. It's about having to train your providers. We had 3 years ago, I looked briefly at growth in kids with HPE, and there's not a growth chart for kids with HPE. There's again a lot of differences and a lot of changes or a variation by diagnosis, and so it's hard to come up with. But at the same time, you don't want to always rely on just a regular growth chart. So I'm going to talk about some what we can do about it, some things that you can be empowered. Hopefully you'll be empowered. There we go. So again, this is my favorite little slide here about what is nutrition influence. And so this came, actually, it's getting old now, but it came from 2016, talking about nutritional status and what does it influence. And so you can see all of these little busy arrows here, but almost everything kind of has some touch affected to it by a child's nutritional status. And as a pediatric dietitian, that's why I think it's so important that we get ahead of the nutrition game, that we start looking at it from birth. Again, Nancy and the team kind of covered it from preconception, about taking your folic acid, making sure you're in the best nutritional health as you start planning a pregnancy. I understand not every pregnancy is planned, but if you're of that mind, even if you're a 20-year-old, a 19-year-old female, go ahead and do that nutrition. Get your folic acid intake up. Make sure you're taking your multivitamin and such. But so again, nutritional status is touching everything from every part of your child. So that's what nutrition influences. And my slides are not wanting to advance. There we go. So then what influences nutrition? So I've put this slide up also to say, it's not just what you're doing as a parent. There are lots of things. So if you have a child that's what you would consider, we'll talk undernutrition first, but if you have a child that's undernourished, there could be micronutrient deficiencies in the child. There could be underweight, which leads to low muscle mass, low fat reserves, and then all of that leads to growth failure. But what is that? That's just not a single thing that sits out there. So does the child have feeding issues? Are there chewing and swallowing problems? As Nancy pointed out, she kind of did the first half of my presentation, so I'll speed talk through some of that. Lots of kids with HPE, of course, have those oral motor issues or even some limitations. If they have good skills in terms of eating, they might have food aversions. They might have some chewing or swallowing issues that are not so severe that you would need a feeding tube. But again, about 75% of the kids at some point in their life will need a feeding tube. A little bit, well, we're going to give you an advertisement for tomorrow. Tomorrow, we're going to talk a little more about just nutrition and talking about if you have a feeding tube, is it possible to do some oral feeding? Are you 100% tube feeding? I will tell you, a lot of years ago when I started in my practice, the strategies for developmental pediatricians were that if you needed a feeding tube, that was the last day that you ate something by mouth. We're much more sophisticated now. We're always looking at maintaining whatever oral motor abilities we think we can put into play. We work with speech therapists, we work with occupational therapists and the physician to say, how much of this do I need to give through the tube? How much can I safely give by mouth? So there's lots of things that go on. And so those are the kind of the child factors. Again, spasticity, low tone, that all changes the child's nutrition. Then there are things that just come, of course, with the holoprosencephaly. Some kids get malabsorption, and we used to think, okay, it's a brain problem, not a gut problem. We're not even thinking about malabsorption. The newest research is showing that any kind of neurologic issue also affects the gut, whether it's hormones being excreted, whether it's enzymes. Somebody was talking a little bit about diabetes insipidus and diabetes mellitus, the type 1, and the relationship to the pancreas, and all of that. Some of that starts in the brain. So again, it's nice to see a more global viewpoint of that. And then if you're talking about, again, in the community, we already mentioned before, do you have someone in your community that can help you understand nutrition for your child? Specialized nutrition. Do you have a dietitian that understands pediatrics. And those are hard to find. I will be giving you some resources in the materials I'm sending to Susan and Steve for just some reference materials. Again, you need to look for those, and sometimes you have to go to the bigger centers. Although, again, talking about technology, there are so many pediatric dietitians that are now doing telehealth. Personally, I'm not set up there. Hopefully will be at some point in my retirement. But telehealth, there are telehealth dietitians that can help you, even if you're living somewhere that a good pediatric dietitian and physician are not available. So any rate, we go back to our quandary as always. If you're talking about good nutrition, we have a tendency, if you're just seeing your PCP or you're just seeing your pediatrician, and I hear this a lot in clinic when they say, oh, my pediatrician said he's way underweight. Well, okay, is that the only measure of him being well nourished? Are we stuck on a particular growth chart? Are we not even looking at the growth chart and we're just looking at pure numbers? So that's kind of always the quandary, and it's always been my quandary about being able to communicate that out even to other nutrition providers, is maybe that's not just pure numbers. When I train new students, train new dietetic interns, or even the med students, I try to get them off the numbers, off the absolute numbers, because there's a lot better ways, and for our kids, more accurate ways to assess their nutrition. So I want to talk about some tools that we can do. And then I want to talk about when do we want to pay in particular attention. Now, again, we already talked a little bit about preconception, making sure your protein intake is good, making sure your folic acid and all of your B vitamins. So a good multivitamin and maybe a little bit of an extra folic acid is beneficial when you're in that preconception and even during your pregnancy. So again, we talk about something called the first 1,000 days, and that is conception to about 3 years of age. So we've covered most of that, but you want to have adequate weight gain. And I did want to talk because it's kind of an interesting thing in the community that I kind of follow around online, talking about the new weight loss meds, the new diabetic meds, the GLP-1s, medicines. And we don't know. What we do know that if a person has struggled to get pregnant, that they're more likely to get pregnant if they've used a GLP-1. Now, again, that's a very, very early study. I just actually read about it on Friday. And they're going, did that cause it, or is there just a correlation? So it's something to understand more about that, but you want to make sure you have adequate weight gain during pregnancy. Again, I know some OBs will say, okay, you're a little overweight, let's just hold your weight steady. As a dietitian, I don't agree with that. That's just a personal opinion. I think you're growing a baby. You need to be willing to have a little bit of weight gain and not be changing how your body is providing its nutrients to your baby. So again, we're looking at crucial nutrients, and that of course is balanced calories, folic acid, zinc, and iron. Make sure you're not iron deficient during your pregnancy. A, you feel horrible, and B, it carries nutrients. The iron helps the blood carry nutrients to your baby. So make sure that for your pregnancy there. And then again, neurologic development, you want to have that other balance. You want to have adequate calories. I keep saying that, I got to quit saying that, but adequate calories, even if it means you stop your weight loss journey at that point and you're nourishing a baby, you have a better outcome than a few pounds the OB might want you to hang on to. So again, adequate calorie intake to support your baby's development, to support their neurologic development. And that means a balanced source of calories. That means maybe come off a low carb diet, maybe look at a better balance, making sure you're getting those carbs where you, that carries the folic acid. A lot of times it carries zinc, it carries iron. So come off the keto. And then you want a balanced, essential fatty acids. You know, we talk about omega-3s and omega-6s and DHA and EPA. And again, with your cholesterol and lots of stuff in the media, some of it's pretty confusing. But you want to make sure that you've got a balanced diet. And again, going back to that basic thing you learned in home ec is the My Plate concept, just a balance of protein, grains, fruits and vegetables, and a little bit of calcium in there to make sure that you're getting some strong bone building material in your diet. And so then another important time, so that's the first 1,000 days. That's from conception to those first couple of days or couple of years of life. And I will tell you that a baby's brain grows the most, does the most development in those first 3 years. In fact, the research says it does more development than it will at any other point in its life in terms of the amount of things that it learns and development and things like memory, ability to lay down memory and learn new materials and such. So anyway, then there's a second time when you go into a growth spurt. And I have this little slide here that is a little bit confusing. So again, the boys are measured on the solid black line, and you see that their height or their centimeters they grow per year. You know, if you're taking a newborn, they grow really rapidly. They'll grow 24 centimeters or roughly 10 inches in that first year. And then it gradually goes down. It's still increasing, but per year. And then again, you think about your average kid's growth spurt. The girls peak in height. We're talking just height at this point. Peak in height between, now this slide's a tiny bit old. Again, it's from, I think it's from 1970 is when they did this study. But girls are now peaking in their linear growth at about 8 to 10. You know, all those 4th and 5th graders are always going to be taller than the boys. And then the boys do their peak height between 13 and 15. So again, you want to keep that in mind if you're looking at a regular growth chart for your child, even if they're non-ambulatory. You're going to hit some points in time when your child needs some additional calories. I try and be aware of that when I'm even adjusting tube feedings. I'm saying, okay, she's heading into her growth spurt. And girls in particular pack on some extra pounds. I'm not worried about that, but I'm going to make sure that they have adequate calories to do that linear growth, because that's just an indicator of across the board growth. And again, for boys a little bit later, they tend not to pack on the pounds. They tend to skinny out and then they do better. But then their max growth for girls is usually at 15. They're as tall as they'll always ever be at about 15. For boys, it's now between 18 and 21. It's just, I think, the way our food supply is, a lot of different things that we have on board. So, okay, so we say that we want you well nourished, but how do you define this? If we're not seeing what's on the growth chart, you know, we're just looking at numbers. We're looking at grams you gained per month for over a period of time. What else can we use to define well nourished? So for me, when I'm talking about a well nourished kid, if I'm doing an evaluation of a patient in clinic, do we set some growth goals, even if they don't fit on the growth chart? I know that some of you have been to the pediatrician and you know that you measure your baby girl and she is below the 5th percentile. She's below, even on some of the WHO growth charts, below that 3rd percentile. And they say, oh, you got to get up to the 5th percentile. Well, maybe not. Each child, particularly in HBE, seems to have their own growth curve. Again, if I were very, very smart and very, very rich, I would make an HBE growth chart, because I think there's some well observed norms that are kind of exhibiting out as we're able to do heights and weights measures, just absolute numbers on kids with HBE. Again, well nourished means, can you recover from that illness? Do you get RSV? Do you get a little pneumonia, something in the middle of the winter? Do you get COVID? Can they recover quickly, or is it a lingering illness? To me, that says you get over it within 12 to 14 days. You've got some good nourishment on board. Again, and then maintaining muscle mass. We're going to look at a way that you can measure muscle mass there. And then just maintaining your other vital functions. Your kidney function healthy, as your GI tract functioning well, that's all a part of good nutrition. And then again, developing strong bones. And I'll share at the end a way that they are now assessing using bone, doing a DEXA scan, doing measurement of your bone density, and using that as an assessment of growth chart. And again, none of these are where do you fit on the growth chart. These are just different criteria. Again, what affects nutrition status? So we've talked about why it's important. And then we talk about what affects it. And so let's talk about some HBE specifics. And again, we know kids have feeding problems. We know that some of them have spasticity that affects how fast you burn your calories. We know that some of the kids have cardiac issues. And then respiratory, is that related to the oral motor skills? Is that related to low tone? And then we have endocrine issues, as Nancy pointed out. About 5% are known to have growth hormone deficiency. So that changes your ability to get up on that growth chart. There's hypothyroidism. And then there's diabetes insipidus. I did find an article that said they suspect of live births, about 60 to 75% of kids have diabetes insipidus. However, I don't think we found that at the Carter Center. I would say more like 40%. But again, all of those things affect nutrition status. And so again, coming back to the feeding issues or a little bit of the facial issues, as we know, as Nancy said, 70 to 80, this says 70, I think that was the research article, but I would say more like 85% if you include those kids that have feeding aversions, problems choosing foods kind of with it, as if they were on the autism spectrum, like having a very, very select diet. I see that a lot. So I would include them. I would make them about 80%. But there's things like reflux. Oh, how many of your kids have reflux? Lots and lots of kids, even if it's just related to low tone. And then reflux and aspiration. Again, a lot of times what you're finding is that you combine these feeding issues, and that's what must lead you usually to a feeding tube. But again, my mantra is, how much can we continue to do by mouth? How much can we do safely? Sometimes, unfortunately, there's no safe feeding, depending on the craniofacial differences, depending on the tone issues, depending on lots of swallowing abilities. So you have to do a feeding tube for all of the issues. But I think that there's maybe 40% of the kids with feeding tubes that can do oral, do some oral feedings if you choose. It's not, it's not always something you have to do, because we can certainly nourish them really well by their tube, but we want to make sure that we are taking good care of them. So let's take a couple of terms. And again, I want you to take the information that I'm bringing as I'm training you to train your providers, whether this is a home care nurse, whether it's a physician, whether it's the PA that you see at urgent care. I want you to be empowered. I want you to say, well, the Carter Center dietitian said. So because sometimes you'll see that little failure to thrive on your charts, and your mom's heart just goes, or your dad's heart just, it's just the worst term ever. I was the mom of a failure to thrive baby. Oh, yes, that hurts. So again, but it doesn't always have a good definition. It's a term they throw out. There are some things like they're below the 3rd percentile, or they failed to gain a certain number of grams per a certain period of time. But it doesn't have, it's not a diagnosis that they should throw around so lightly. And again, this kind of came out, it's a nice article from the American Family Physician. I put the reference on here, and I'll be sending that information to you later if you're interested. But they brought up the fact that don't throw that term around like it's nothing because they're underweight. You need to use that more carefully and say, what is it? Is it a failure to thrive, or is it related to something else? So again, if we failure to thrive, sometimes undernutrition is a little better term, because undernutrition says it's not wed to a number in a book on a chart. It says undernutrition, again, the definition is right here, unbalanced or abnormal utilization of nutrients, which causes adverse effects on tissue function, body size, composition, and then it has some subsequent impact on health outcomes. So really what that's saying is that it's not a general term, it's something specific. So if your child is having feeding issues, or they have really high tone, or they have bad reflux that keeps you from having the ability to get good nutrition, they can be undernourished. It's just a different term, but I think it has a huge meaning there. So again, if we're going to say failure to thrive, this is what they're looking at on those growth charts that you see. And now you don't really see those little blue and pink ones anymore, because they're usually on the electronic medical record. But it's a decelerated or arrested physical growth. So it means if you're kind of sliding off the growth curve from any sense, you shouldn't be. If you're sliding off the height curve, they've measured you wrong, but on the weight curve, if you're sliding there where you should be gaining, the blue lines or the pink lines are saying this is where you should be going, but you're not. Something's going through and you end up below the 3rd percentile, you can be technically classified as failure to thrive. Again, as a general term, but not as an actual diagnosis. So it's a downward change in growth across 2 percentiles. So for me, if I'm looking at that change, I would not say failure to thrive. I would say undernourished and say, what are we going to do? Because undernourished says we can do something about it. Failure to thrive is a prescription, is a something. Again, you can tell I don't like that term. So any rate, so then we have another thing called growth faltering. Now, growth faltering is more related to undernutrition. So you can see that, I don't know if you can see my little cursor, but as we're moving here growth-wise, still below the 3rd percentile, but the growth curve is moving up here, and the height measurements are not, they're moving. He's having some linear growth, but it's not moving quite at the same rate. So that says growth faltering. Again, you'll see the same thing weight-wise. I will tell you that in children below about 6 or 7, when they're doing good linear growth, the weight changes, the weight will slow down. And then about 6 months later, you'll start seeing changes in the trajectory or the velocity of the linear growth. So a little bit technical, but just to kind of give you a feel for what you might look at on the growth chart. Now, again, what does it require? Good measurements. So, so we're going to talk about that in just a second, but it's the strongest predictor of poor nutritional status. Again, if this particular child had stayed below the 3rd percentile and all the percentiles, but they mimicked the growth curve, that is not growth faltering. That is not failure to thrive. That is a kid setting their own mark. Same thing with weight. If you are below the 3rd percentile and you're just continuing up that trend and going from, this was a baby one, and he's moving from about 7 months here to just about 15 months, then what you're seeing is you're moving along here, but we're just not coming off here. This says we probably need a little help here in the nutrition category. So that's growth faltering. Again, more related to undernutrition than absolute failure to thrive. So, see if I can admit this person, keep them waiting. So again, what do we say in overnourished? Let's take a minute and talk about overnourished. I recently had a mom call me. She told me I can use her as an example. And her new pediatrician, fresh out of the med school farm, said, oh, your child is too fat. She's gained too many pounds. You gained this many grams. And if she continues to gain this many grams, she's going to be way overweight by the time she's 15. Well, it was one measurement or two measurements, one measurement here, one measurement there. You can't tell anything. One set of measurements does not tell you anything. It's like gas, you buy gas one time at $3.29 and you buy gas next week at $3.59. You can't extrapolate and say, oh my heavens, by Christmas, gas is going to be $7 a gallon. I use that same analogy when I talk about weight. It's two measurements. They don't always stay. And then again, it's based on accuracy of that. So you're going to ask here, your empowering tip number one. Somebody says that to you, say, can I come back in a month and let's do a remeasurement? Let's make sure this wasn't a bad number or just a bad observation. So now it can be related to endocrine issues or thyroid issues that, again, that determine or change how fast a child uses their calories. And then it could be related to overfeeding. Oh, I'm the first one. I'm a dietitian. I'm a happy feeder. It could be related to overfeeding, and especially when you first started the tube feedings. You've gone from struggling to get your child to eat, and now you have a tube feeding. Whew. Okay. And then we want to get a little bit of catch-up weight gain. We want to fix that undernutrition or kind of treat that undernutrition. You come back and see me and I have fixed you real good. So again, that's when I see overnourished is when and overfeeding is when a dietitian has said, yeah, we're going to do this. Especially here's my little chart. Here's my book. And I have this great book that I use. You can see it's all marked up. I have this great book that I use that tells me typically how many calories a child needs. It doesn't always count. It doesn't always work, especially in HPE and especially in cerebral palsy. So you've got to use your numbers. At any rate, so there's a lot of things that can be related to. But again, before you let a physician make a big old change in your feeding regimen, get a repeat. Say, I'll come back in a month. I will go home and do some better weights. Let's do some other measurements. And don't change more than 10% at a time. What I have seen from other providers is you go from overnourished to undernourished because you've made a big old change. They said, oh, your child needs 67 calories per kilogram. I don't know how they get that close, but 67 calories a kilogram, we're going to take them down to 40. Well, then you come back, you've had no weight gain for the 9 months between the time you see the physician one time and the other, and now you have the opposite issue. So again, 10%, don't let them change more than 10%. And again, this is what I'm hoping to share with physicians and dietitians that move cautiously in that sense. There we go. Okay. Sorry, I have a little trouble with my slides here. So let's look again. Let's go back and say, we're not going to look at the growth chart. We're going to understand the growth chart because that's going to be our common language with the provider, the dietitian, the nurse practitioner, the physician. So we have to understand how that works. But at the same time, I don't think it's the end all and be all. And I guess if I had a theme for my presentation today, it was, let's look at the whole child, a whole child assessment. So the first thing there, I think there's 5 key elements, and we're only going to talk, we only have time today because I talked too much about other stuff, but we have, so we're going to look at, I consider there 5 key elements. And so we've talked a little bit about anthrometrics, and I have a couple of slides to talk about things you can do at home, some ways of making some adjustments in the your weights in between the times when you get to see your physician. So it's anthrometrics, laboratory values. We'll talk a bit about that. Typically now, you're probably only going to get lab values unless there's something big going on about once a year. So you can't, it's a good point for nutrition assessment, but you're not always going to get it. Insurance is not going to pay for it as often as they might have 20 years ago. Then you want to know your dietitian or your physician is going to say, tell me about what they're eating. Tell me about their tube feeding. tell me how many days they vomit or what their tolerance history is. Have you had to change formulas? So see what that is. I can take that information. I can say, okay, you've been getting 1,200 calories from your Nourish or your Pediasure peptide. But you're telling me that 3 days a week, you're losing your whole evening feeding. Well, I'm going to average that out and say, okay, well, you're actually getting maybe 1,000 calories a day or some number. So I'm going to look at that. So I want the physician to kind of look at that. Again, undernourished kids and they're having formula tolerance issues. And they say, well, we prescribed you 5 boxes of Pediasure 1.5. And you're going, well, no, we're only getting 3.5 in. So you want to, they need to take that into consideration and remind them. Again, you're training your provider. Then you want to know the previous medical history, and that's your physician. Kind of work with them on that to say, I know I only see you once a year, but did you know, and this is better with the electronic medical record, but did you know my child was in the hospital for 3 weeks with pancreatitis and we did only IV fluid? So again, make sure that they're considering all of that. And again, a physical exam, we're going to talk a little bit about that in terms of alternative measurements. So again, in my speech, having a good baseline growth assessment, because kids can become malnourished quickly if their nutritional intake, pancreatitis, somebody gets crazy with your tube feeding regimen, or you have some kind of bout of bowel GI gastritis, and your ability to get formula in and get it absorbed is interrupted. So you can see those changes, and I see that in my whole special needs population. Is sometimes I'm looking at the mouth, I'm looking at the G-tube, and I forget to look below the belly button. What's that absorption like? How much diarrhea are you having? How, what's the quality of the stool output? Because is it really loose, and am I losing nutrients at that point? So accurate measurements, again, allow early intervention. So accurate measurements of tube feeding intake, accurate measurements of length, of weight, of all of that stuff. It's important. So, okay, so what do we do with that? How do we measure well-nourished? So let's talk about height and weight, since we've been talking a little bit about growth failure and overnutrition. Again, so in a typical pediatrician's office, you're going to have that stadiometer. You're going to have, the little height board, or it might be a Scottish Rite. It's attached to the wall. You might have a length board. You might have a non-flexible tape. Those are ideal. Sometimes what you have is an exam table and someone with a 14-inch paper tape measure. I wish I could, if we were in person, I would make you raise your hand to say how many times has your big child, been measured with a 14-inch paper tape measure, and you already know the number is bad. So there's better ways, there's adequate ways, and then there's ideal ways. So again, you want to look at that. And so again, measurement and height. I use this slide when I do classes for the dietetic interns, and I ask them to tell me what is wrong with that height measurement. The goal is hats off, hair bows. Hopefully they don't have lots of braids up there if they're able to stand. Take the shoes off, all kinds of things. But if you look at this girl, her head's down, her chin's down. So the nurse is actually measuring her, and she's not standing up very straight. And he's actually measuring the top of the back of her head. You can have, that might be 2 centimeters. That could be a full inch difference. So again, there's better measurements, but I could not find a slide. It's been interesting. I can't find a slide of a accurate standing height. And I have the whole internet to search. So again, we look at, so if your child is not able to stand up and they are not ambulatory, you want to do something called a recumbent length. So looking at this baby, this is the measuring board, we call it the length board. Almost every pediatrician's office has one. Almost every pediatrician's office hates to use them. So, but we can see even this best board, horrible technique. For some reason, this baby's foot's not on the height board and they're not using the top of the board. A nurse or someone, it's a two-person technique. Someone is just holding the head, but they're using that paper tape again. Get me off my soapbox there about paper tapes. But again, so it looks good technique, but it's not. As you look at that, it could be, but it's not. And then look over here. This is really bad technique. So she's measuring the feet, but he's already scrunched over. Nobody's holding his head steady. And you, again, if you're measuring height and you're looking at undernutrition, you know, a matter of an inch or an inch and a half can make your trajectory when we're going back there and looking at failure to thrive or undernutrition. It's messing up your whole trajectory. So as parents, be fierce. Just say, let me help hold the head. Can we use the height board? Can we, you know, let's look at our technique here again, because it's going to go on your growth chart. So then weight-wise, you know, we don't have very many alternatives. At least in height, we have a recumbent board, and we're going to show you an alternative to measuring height shortly. But we have the infant scale, we have the standing scale, we have a wheelchair scale, we have a lift scale, we have a bed scale. I can tell you that as you move up, especially through the standing scale, the wheelchair, the lift, and the bed scale, we did a thing here at Scottish Rite about 8 years ago, and we took a child and we put them on every single one of these things that we had, and we were off by 5 pounds, depending on which scale we used. And we had the same kid, we hadn't fed him or anything. So we had such a discrepancy. So again, you want to be, I think consistency is the key on your home scale. If you're going to weigh and measure, if you're going to pick up your child and step on the scale, then subtract your weight, make it the same time of day, the same person. The least, I should put a caveat there, the least amount of clothes on the child you're weighing. You don't have to get down to your skivvies of your own to pick up your child. But on your home scale, just make sure it's consistent. It's a decent way of tracking. It's not as perfect as a hospital-based scale, but if your technique is good, that's perfect. That's perfect. In a medical office, ask for that scale to be zeroed. In your little notebook that Steve and Susan recommended, write down which scale was used. Again, take off those shoes, take off those winter boots, that's coming up. Ask the scale to be zeroed. See if they will let you peek. Look whether there's paper on the scale or not paper. Again, looks minor, but when they're evaluating your child's growth, little things matter. In a hospital clinic, note whether it's the bed scale or the wheelchair scale. If you have a wheelchair weight, get that reweighed when you change cushions, when you change back supports as they grow. Your wheelchair for your child is not going to weigh the same at 8 as it's going to weigh at 17. There's just going to be so many changes that can happen. So put that down. Again, be fierce, ask for a repeat. If that number seems off, if your handy dandy notebook says, 6 months ago, we weighed 42 kilos, and today you're saying they weigh 57, and he looks the same and he's still wearing the same pants, then make them change. Make them change that. They don't like me down in clinic when I'm hanging around the height and weight room, because I'm going to go, you didn't zero. Yes, I did. You know, or let's take your shoes off, or let's take mom's purse off the bed scale. So all of that, again, this is important. It's guiding the treatment of your child. It's guiding how we do their nutrition. So as a dietitian, I'm obsessed over heights and weights or good measurements. So again, bringing back my growth charts, I had to bring a girl on here and a little bit older girl. It's a comparison tool. So you're going to use it. You're going to write down these things, but you're not going to use it as the actual. Don't use a growth chart to make a diagnosis of anything. Overnutrition or undernutrition, you have to have the whole picture. And then you're going to look for trends over time. This is the BMI chart for kids, for a girl from 2 to 20, the BMI chart. But I don't love BMI because our heights and weights are not always accurate. They don't always fit our diagnoses. So I've begun to use these scores more than I'm using BMI, because this you might have two very well-nourished kids. Here, sitting above the 95th percentile BMI for age because they are not as tall or they're not as long as another child of that age. And this child may be very, very long. I know that some of our HBE kids, and I've just noticed this as a trend, some of our HBE kids are really tall, like fit if on the regular growth chart, they fit at the 95th percentile. They look pretty good, or we're working to get their weight to catch up to their height. But so use it as a comparison, not as an absolute locked in tool. So, and again, growth charts. There's so many. Like there's all of this on the normal. We use typically your physician's office after infancy will use the CDC growth charts. And so they have weight for age and height for age and weight for height and head circumference from birth to 36 months. 2 to 20, you're not going to measure necessarily head circumference, but you're going to have all of that, and then you're going to have BMI. And again, all of these are sex specific. And then there's disease specific ones. I've been seeing some use of the cerebral palsy growth charts on kids with HPE. To be honest, I don't have a good reason. I just don't love the results I get. I don't love the way they plot on the CP chart. I would rather plot them on the CDC, the regular standard growth charts, and then maybe look at them on another growth chart. But yeah, I don't want to necessarily use that as a gold standard. And I am seeing that some, one of the pediatricians and I kind of have agreed to disagree for HPE, but yeah, use the regular ones if you get a choice. So then let's look at growth velocity. I keep bringing that up, but I think that's a better key indicator of good nutrition than it is absolute numbers on a growth chart. So in linear growth, again, accurate measurements being staying unsaid, but our goal is a gradual increase. So the it indicates a good balance of protein and micronutrients. Linear growth is driven by protein and micronutrients supported by calories. And weight change is mostly calories and other macronutrients or micronutrients, such as calcium and the vitamins, folic acid, iron, zinc, all of that. But this little table is a little bit old. It's from 1982. And so the numbers, again, knowing that in general, kids are better nourished. But you can see early on, under 3 months, they are gaining, weight gain is 25 grams a day. By the time they get to be 7 to 10, and this is the most accurate, after 10, girls and boys diverge so much, you're not going to see that. And then so it's hard to say, oh, it would be like 5 to 25 grams per day, depending on where they are in their growth spurt. And the same thing with length. When they're tiny, when they're under 3 months, average weight length, average again, not specific, but average length is 2.5 centimeters to 3.5 centimeters per month. You won't see weight. You can't find an accurate length to measure like, oh, by the day. But over a month, you're going to see those changes. Same sort of thing. You got a lot of growth in that first 3 months and then less. By the time they get to be 7 to 10, the numbers really diverge and it's hard to say, oh, they should be growing there for growth velocity. But in between here, between infancy and about 7 years old, it's pretty predictable. You can see from 6 to 12 months, you're growing a lot. You see those babies just, you put your neighbor's baby at 3 months next to your 14-month-old, and it's like a huge difference, a whole different body shape. So just knowing that's there, but again, it's velocity, it's not absolute numbers. So kind of bashed all over the growth charts and linear measurements and all of that. So do we have some alternatives? And so I want to show you some alternatives. I know we looked at this for those of you that were here 3 years ago. I kind of cleaned up this slide a little bit and I thought it was easier. And when I send it to you, you can have a measurement that's a little better. But ulna length, so the whole theory behind this is that our long bones grow all the same time, or the same velocity, the same number of centimeters at a time. So you can do a knee height measurement, you can do a hip to knee measurement. Those are harder to get to for some kids. But an ulnar length, you can always get their hand up there. And I don't know if you guys can see me or you're just looking at my slides, but I'm afraid to stop sharing. But you can see, so you're measuring from the bony part of your arm all the way down to the tip of your elbow. So the styloid process, which is that bony part of your ulna, and that's the outside bone, all the way down to the tip of your elbow, that's the olecranon. And so you can do that at home. You can track that number. So the equation is here. Again, I'm going to send this to you. It's from Developmental Medicine 2004, but the calculation is still the same. And you can measure if you have a child that has a lot of contractures, they have scoliosis, they're very, very hard to measure. The ulna bone, again, has grown in the same as if we could stretch your child completely out, stretch them out with no contractures, no scoliosis, no hydrocephalus. This gives you an idea. You can use the math, doing a little math measurement, and then get something that you can plot on the growth chart to see, is there a change over time? I do ulna lengths on almost all my kids, only because I know that my linear measurements that are being done are not always the best, or I can't always count on them from different facilities to be anywhere close to accurate. But again, you can play with this. Now, I can tell you also that this is the calculation for children, or children up to age 18. For men, it's kind of up to 20. But after that, again, women have hit their growth potential. There's a table. I couldn't get a printable copy here, but if you want to know how tall you are, you can measure your ulna and look it up on the table as an adult and find out how tall you really are. So anyway, it's an interesting thing to look at. But again, for your kid, if you don't feel like you can do a good linear measurement, then do an ulna length, and that extrapolates off to if you do your math right, then it extrapolates off to your linear height. So again, we're looking at measurements. If we're looking at body composition, again, we know in holoprosencephaly that some kids are tall, some kids are really short. I don't see a big correlation. Again, it's not a scientific study, but just my gestalt, my feeling on it is that there's not a difference between when you have a tall kid because they are an MIH, or you have a very short kid because they are a lobar HPE. I'm not seeing that. I wish I had data and the ability to kind of compare all that out, but I don't see that. But I do see lots of changes and lots of differences in the kids with HPE. So your typical BMI in a kid with HPE, it's probably going to give you some number that doesn't look like your child. So, and it's extrapolated from weight and height. And again, if it's not accurate, you're going to get a weird BMI. And it does not factor BMI as the growth charts on the growth chart does not factor in disease state or in a physical disability. However, you can do a couple of different things that are alternatives, and these are well documented and well studied. One is the mid-arm muscle circumference. Then you can do tricep skin folds. You can do a DEXA scan. We're going to talk about that in a minute. And a new thing called a bioelectrical impedance analysis. Big thing, you won't find that at home. You have to find it mostly in the university medical centers because they're doing research on it. So again, what you want to do, the idea of assessing body composition is you're understanding that ratio between lean body mass, which is your muscles, your organs, to the body fat. Gives you a better sense, particularly when we don't exactly have an ability to say they should be weighing this at this point in time. And again, you can see it's a good picture. For me, it's a good picture of how a kid is doing. It's a response to treatment. We would do for here, if I was doing a brand new feeding tube and a child that was undernourished, I would do a MUAC, that's the mid upper arm circumference. And then I'm going to compare that at 6 months. We might have seen a big jump in their weight, but then their arm circumference hasn't changed, which means I'm okay. I'm just repleting them, but I've not added a bunch of body fat. So again, it can stand in for weight when there are lots of things like hydrocephalus or edema or missing limbs. If I have a child that is born without legs, then there's kind of calculations, but not good ones. So a MUAC, a mid upper arm circumference, I can use a tape measure. Super easy. And I can show you kind of what I'm looking at. So this is a tape measure that you can use. You can find them on Amazon. I found them on Amazon. You have to buy 10 at a time, but they were not expensive. And they give you a feel for what that muscle circumference is. Again, it's because we know the bone in your average 6-year-old is going to be the same density or the same circumference as a child that doesn't have a disability. So it's going to be about the same. And then you know that there's an average amount of muscle for a child, regardless of their physical activity, regardless of that. If they're not bodybuilders, then that's a whole nother thing. But even in the high tone kids that seem to have lots of muscle, it's pretty average. And so what they use this mid upper arm circumference, like it says here in my little slide, you have in the red, if they measure in the red, and that's generally below 11.5 centimeters, that's some bad acute malnutrition. We have some need for some better nutrition. If you're sitting in the yellow span, which is about 12 for your average kid, again, it's really set for a period of time. So you've got some issues there. What you want to look is, again, you're looking at a trend. You don't want it to move too much unless you're moving it in the positive. You don't want to move it backwards into the red area. And then again, anything in the green is perfectly normal. It's exactly where you want to be. So if you had a rapid growth spurt or you had pancreatitis, spent 3 weeks in the hospital, you can do, the weight. Then we say, oh gosh, are they dehydrated? Did we overhydrate them? And you don't get a good number, but you can do a mid upper arm circumference and get a number that says, oh, last time we measured his mid upper arm circumference, he was 16 centimeters, and now we're down to 12. We probably need to do some nutritional repletion. So again, here's the directions. I feel like I'm using up my time really quickly. So it's measured, and again, I'll send this in the slides. It's from the left upper arm at a point halfway between the acromion and the olecranon. And did I get that slide in there? So again, you're going to bend the arm. Let me stop sharing for just 1 second and show you this on my own arm if I can. Oh, no, that's not going to work. Okay, that's okay. Oh, now I got to get my slides back. Okay, we can talk about it later, but at any rate, it's a good way to look at malnutrition or nutritional repletion when the other measurements, again, are difficult to compare to normal. So you can see here in the numbers and the girls, I about cut that girls' numbers off. What I wanted to show you is that this is the age in months, so this is to about 6. You can see the numbers change some, but then really they a little bit stay about the same. If we look at the max, for gosh, for the whole time from 2 to 6, you're looking at the same number as kind of they don't have the average. They have an average over here, but and the max. But that's again because the body shape is changing so much. You can see the same sort of thing over here with the girls, your max there. So let's talk a little bit about bone age. So some of your kids will have had a bone scan looking for bone age, or they might be looking for osteoporosis. They might be looking for osteopenia. And so they found when they were doing all of this having the technology to measure their bone age, is that they could say if the growth plate is open, then that gives them an assessment. They know how to read these to say, okay, they must be, their bone age is 4, and they could be 6, and it says, oh, they still have lots of growth potential. Or they could say, oh, it looks like their growth plate closed early, and then so they kind of hit their height potential. But again, it's a measure of skeletal maturity. It says your ulna's not going to grow. Even if you do an ulna length, you're not going to have much more linear growth if your growth plate is closed. So again, skeletal age. If you have a long period of malnutrition, you might have still an open growth plate, or you might be shorter and you have a closed growth plate. You're not going to get much recovery there. Now, again, what we have used it in several other clinics for is to estimate the potential for catch-up growth. Like, can I expect to give this kid good nutrition for the next 2 years, and then I will see some linear growth, not probably catching back up to the 25th percentile on a regular growth chart, but something, we'll see some potential. And then again, it might be a sign of rickets. We found rickets more than we've thought, not so much in tube-fed kids, but in orally fed kids, because they don't get enough calcium and vitamin D in their diet. And that's another topic. So we will cover that, but it's another way to assess nutritional status. So Z-scores, let's talk quickly about Z-scores. It's an alternative way to interpret changes in height, weight, and weight for age and BMI. Again, a Z-score scientifically says it defines how far away you are from the average measurement, or how far your measurement is away from the average measurement. And again, it's sensitive to smaller changes. So you might hear your pediatrician say, oh, her weight is now at a negative 2.5, and that indicates malnutrition. Now that would be true because we've compared changes between one Z-score and the other Z-score. So if I calculate Z-score for weight for your child, I'm going to say, oh, they've moved from they currently have a Z-score of a -2. That means undernourished. And we have managed, when we started their feeding tubes, we've moved them to a -1. Still sounds like a -1. That feels bad to us. But I've moved them a whole standard deviation, which is a really good thing. Probably scientists could explain that a little bit better. But again, when I look at that, and then again in the overnourished state, if you have a +2, the doctor might say, oh, your weight Z-score is a +2. We would really like them closer to a 1. Now, we're not going to subtract things out. We're going to let them grow into that over time.
Our afternoon sessions will be starting shortly, and just want to remind everybody, if you did not see in the chat, please register to join us for Dr. Paul Krushka and for our 2 to 3 p.m. Afternoon session with Angela Schreck and JD Delatorre. So we'll be seeing you in just a little bit. And just a reminder that Janice will be back at 11:45 tomorrow. So if you have questions, it's going to be an open discussion, Q&A, and you'll be able to share ideas and ask questions about nutrition at that time.
Thank you, Janice, for your time.
All right.
Yeah,
Well,
thanks so much. Thank you. We really love the way you empower parents and encouraging parents to be fierce. So thanks so much for all the great information, and looking forward to having you back tomorrow to talk with them at 11:45. Then we'll have a little Q&A then.
All righty. Thank you. Thank you.
Thanks.
Okay.